And good afternoon, everybody. Welcome to another episode of Get in the Herd, the McShin Foundation's recovery podcast, award-winning recovery podcast. My name is Nathan Mitchell. I'm outreach director here at the McShin Foundation, and welcome to everybody. Today, we have as a special guest in our space, we have Tom Jackson, who is a registered peer recovery specialist at Western State Hospital. Tom comes to us also as a founding, well, not a founding, what's the word I'm looking for?
Semi-founding.
Well, wait, you don't know where I'm going with this.
Okay, I don't. I should be careful.
Oh, maybe. As a state lead, that's the word I'm looking for, with the Virginia Recovery Advocacy Project, has been instrumental in advancing and coordinating efforts at the grassroots level to bring about some real change here. I love it. Thank you, Tom. So welcome, Tom. Great to have you on the show. I am so excited because we've known each other for
getting on a year,
and we're meeting face to face yesterday
for the first
time during this whole COVID thing. But also, I'm excited because through the journey we have several parallels in our recovery. But you celebrated 30 years in recovery recently.
May 13th. Triple X.
Triple X. I love it.
Tres Equis, as somebody said, which was actually one of my favorite Mexican beers back in the day. So,
well, it was dos. Was it
just Tres Equis?
Is it Tres Equis?
In Mexico? Yeah.
Oh, geez, I better be careful. So,
yeah, be careful.
Well, welcome to the show.
Thanks.
I know that you had some things you wanted to discuss right off the bat, so I'll let you go ahead and do that.
Yeah, the main thing is just a disclosure that as a Commonwealth employee, I am speaking on my own behalf, not anybody else's. And as 12-step programs say, we have no opinions on outside issues. I have lots. So you'll hear some of those. I just went to the high noon AA meeting downstairs.
Oof.
And was chilled to see 7 canvases on the walls with the names of people that you all have lost in the last handful of years. And, it just reminds me about what a deadly condition, both substance use and mental health conditions we're talking about. That, since COVID, ODs are up better part of 20%. Synthetic opioids in BIPOC communities are up closer to 40%. And since mental health issues are a big part of my history, suicides are up about 20% as well. So we're talking about really deadly stuff.
And we're talking at a time, too, when access to effective peer recovery support services, or treatment, let me not just go straight to the recovery, but treatment and recovery support services have been limited by COVID, but also, when we're talking marginalized communities, the BIPOC, the LGBTQIA plus communities, we're talking an extra added layer of inaccessibility. We're talking, so it's great to have you here to talk about that.
I worked at a crisis stabilization unit for Community Services Board for 6 years. And when they reopened after COVID, they went from 14 beds because a bunch were doubles to 8.
Wow.
So they lost almost 50% of their capacity just because of COVID.
At a time when the numbers are showing that individuals are getting into and doubling down. So when we need more resources, we're actually taking away the resources.
Yeah, exactly. Now, hopefully that's easing up some.
Hopefully, yeah. And it's really encouraging if you look, the 10% set aside for recovery support services that is in the Biden budget this year, whether that gets passed or not. I mean, certainly we have to advocate for that. But this is a historic first where the federal administration is acknowledging the importance of the peer recovery support services. And of course, I come from a substance use disorder background, and the mental health is there, but you have much more of a thumb on that. Where does that money go? I mean, well, I know you want.
I don't know where. I mean, that's the advocacy we're working on.
Yeah.
Where is the money going to go? Is it going to go to community services boards? Is it going to go to places like McShin? Is it going to go to other peer-run organizations? I think that's one of the things that we're advocating for. Is that it go to more community-based peer-run organizations.
Yeah. Well, what do you see as the value of it? You've worked for the community services boards. You've worked for the Virginia Department. You continue to work for DBHDS, the Virginia Department of Behavioral Health and Developmental Services. What is the value that the non-governmental organizations, these peer-run led groups, what is that value to the whole continuum of care.
Well, they're a lot more person-centered because they're run almost exclusively by people with lived experience. And there's the famous phrase, nothing about us without us. And so the community-based organizations have that peer focus, whereas more and more organizations are bringing peers in. And in some cases at significant levels, at some cases, and I've had a couple of not so great experiences in the last 2 or 3 years working in organizations that brought a peer in but didn't have the wherewithal to adequately support, supervise, and in one case reimburse peer services. A lot of that goes back to one of our advocacy points, which is that the Medicaid reimbursement rates for peer services are so bad you could almost say they're disgusting. I mean, they're insulting. They are so low. You really cannot afford to hire and pay a living wage to a full-time peer specialist in Virginia when you add benefits in and so on, and pay them a $15 an hour living wage and not lose money on them because the reimbursement rates are so low. Hopefully, the General Assembly will get around to that in January, February, and maybe we'll see some changes. But again, that's something that we're advocating for as part of RAP, the Recovery Advocacy Project.
Well, I know that you've taken a lot of notes, and I know you brought this to. Do you? And I know that we could sit here and have a long conversation about a lot of different things, but I want to ensure that I think I'm not really often tongue-tied, Tom. Usually it's at the end of the hour. We've had such a good conversation leading up to this minute, right? But, your recovery journey, that 30 years, and the fact that you are still in the space and still doing this work. I look at people like you. I look at people like, like John Shinholzer, one of the founders here at McShin, who's, I think 39, something like that.
Close to 40.
Close to 40. I think of Charlie Brook, who was a man who, when I first got out of jail in Warrenton, who took me by the hand. I didn't know the guy, and he worked for McShin, and he took me by the hand. He's got the same, like 38 or 39 years, and said, I'm going to help you while you can't help yourself. And so I see that's so important. But what got you to this place? What got you to what you do now?
Well, hitting bottom and bouncing was the main thing. I got sober in 1991. In 93, I had my first mental health crisis. And that kind of went up and down all the way till 97. I was living in Hawaii. My life sort of crashed. I came to Virginia to stay with my best friends forever, had another crisis, and then really totally by accident came into community mental health. I was homeless. I was staying at the Salvation Army, and they sent me to Region 10, the CSB. And within 2 months, the therapist that they assigned me to there, who since became a colleague, basically said, "Oh, by the way, I know somebody who runs co-occurring disorder recovery housing. He's looking for 2 house managers." And so, I had an interview on a Thursday, and on a Saturday, I had 12 hours a week salary, a roof over my head, free internet, free cable. And it was the internet that was the most important part.
This is what, 97, you said?
And that was in 2002.
2008.
Yeah.
Okay, internet, yeah.
And that was in 2002. And then, I got promoted to full-time. I got promoted to another position. I got promoted to another position and just kind of worked my way up, and retired a few years ago as one of the program managers at Region 10's Crisis Day Unit Wellness Recovery, which is known statewide for doing a really, really good job for 14 days of crisis stabilization.
Yeah.
And actually, when we get to talking about harm reduction a little, which is something that we've been talking about with RAP, I've got a great story from there whenever we get to that.
Well, yeah. Well, but I do want to acknowledge Cambria up here. Cambria, I know, is a good friend of Kyle Sunday, who you may or may not have met yet, but he's been on the show a few times. Cambria says, hitting bottom and bouncing. I like that phrase. And I thought the same thing, Cambria. When I heard it, I was like, oh, yeah, that's great. That's exactly. Yeah. Well, so with the work that you've done, right? So you're about to celebrate 20 years with
in community mental health and state mental health. Yeah.
That's amazing. How do you stay fresh?
Oh boy.
Ready to serve.
There are days I don't. But it's and actually that leads into something that we focus on a lot at the hospital, something called Wellness Recovery Action Planning, WRAP, which is an evidence-based, 5-principled process that has certainly kept me happy, sane, sober, and out of crisis. My last hospitalization was in 2010. So going on, actually just celebrated 11 years since that. And it's interesting because I say that my sobriety started in 91. My recovery started when I took the recovery housing job in 2002, and my true wellness started in 2010 with my last hospitalization. That there was a significant difference between those three things. And we talk about the difference between what's the difference between wellness and recovery. Recovery is the journey, wellness is the destination.
Wellness is the destination.
Yeah. And so we kind of talk about it. And and almost everything we do at the hospital has to be evidence-based. WRAP is evidence-based. It goes back to 97. It's been researched. And there was a woman named Mary Ellen Copeland who had been hospitalized several times. Her mother had been hospitalized for decades and was told that she would never get out of the hospital she was in. And Mary Ellen said, wait a minute, there's got to be a better answer. And she started doing some focus groups. I can't remember whether it was 80 or 120 people in the late 90s, and said, how did you stay out of the hospital? And she put that together in this program. And it's based on 5 things: hope, personal responsibility. Now, the word responsibility for me has negative connotations because I was told since I was about that high that I was not the most responsible person on the planet.
Yeah, right.
So I like to say ownership instead of responsibility. For me, it's got less baggage to it. But then education, self-advocacy, and forming a circle of support. And those 5 key concepts are what I work with people around. I work a lot with people with self-advocacy, people who have, they've been beaten down by the mental health system, quite frankly, and teaching them that they can advocate for themselves, and helping them. I mean, literally, sometimes just making a list. Sometimes it's that simple. They've never walked into any kind of treatment meeting, appointment, or whatever with a list. So teach them how to make a list. Some of the stuff is just incredibly, incredibly simple. And forming a circle of support that works for them. And one part of wrapping what's called a crisis plan has, these are the people I want to help, and these are the people I don't want to help, or these are the people that I don't want to help me with this particular thing. One of my colleagues uses it as an example of, this person can help with these things and does a great job and can't help with these specific things. And so that person's plan says, I want you to do this. I don't want you to do that. And so, and that kind of leads to what I wanted to say about a little bit of stuff about what we're doing in the state hospital system. And peer support is becoming an increasingly important component. I mean, the first of those 5 key principles is hope. And we can show people hope that we've gotten better, we've stayed better, we haven't been hospitalized in a long time, we've stayed sober for a long time, and so on. Eastern State in Williamsburg has a volunteer program to get peers there 500 hours for certification. There's some really innovative jail programs, especially in Southwestern Virginia, for peers. We have 2.5 full-time peers. Other state hospitals do too. Private hospitals are doing the same thing. One of my former coworkers is doing some work at 5 East at UVA.
Wow!
So it's really spreading out in institutions.
So what education have you since 2002 and going into your role as a house manager? What have you done? You've become a registered peer recovery support service
and a trainer,
which is how you know Jesse. That's right. Yeah, Jesse Wasaki, our chief operating officer. Yeah, I see you laughing at me, Justin. I can't say his name without going Wasaki. Or even worse, I'll start to rap. Wasaki when I. Anyway,
go ahead. That's fine.
We talked about ADD earlier today. It's a theme with me, and I've been giddy all day. I've been really excited to have you because this conversation is like the piece that I know is missing for me.
Okay.
And as far as my knowledge base goes, and probably for me too, I mean, is what I need for my recovery. But the RAP, the Wellness Recovery Action Plan, it's something that I'm familiar with. I've taken the training, and I didn't end up. I haven't taken the test yet. It's not. I'm not reimbursed by Medicaid.
Right,
It's
exactly.
not. It doesn't really affect me, other than the knowledge, And
And I work with people who are resistant to taking the certification exam, for being a peer specialist. And what I tell people is it advances the profession for all of us. The certification rate in Virginia is terrible. I went to a focus group that DBHDS did through VCU year and a half, 2 years ago, because it was pre-COVID. And something like 15% of the people that have taken the training have become certified. Now,
Oh,
a
wow.
big part of that, especially with COVID, is trying to find some place to do the 500 hours. I mean, you've hit that 5 times, 10 times over,
Right.
probably.
Yeah.
But most people haven't.
Right.
And finding the opportunities to do that, that's why I'm hoping to do something similar at the hospital, maybe sometime next year.
Oh, wow.
And have 1 or 2 interns in to work on getting their 500 hours. Because there aren't very many places to do it. I mean, the only thing really during COVID was there were a couple of peer-based warm lines, and you could get maybe 8 hours a week of time. Well, it takes a long time to get 500 hours at 8 hours a week.
Yeah.
But it really is going to advance all of us. The more people that get certified, the more it's going to enhance us as professionals. When people at the hospital introduce us in orientation and so on, they start by saying, well, this is a person with lived experience, ... What I really want them to say is, this is a trained and certified person with lived experience.
Oh, yeah, right.
Doesn't that bring us up in everybody's eyes as we're professionals?
Right. Yeah.
We've been trained, we've been certified, and so on. So that's my pitch for certification.
I like that. I'm stumbling today. I was in the car with Kyle, actually, with Kyle Sunday. We ran to my house before the show, and we were talking about the process of becoming a peer recovery specialist. We were talking about the show and what the conversation you and I would have, and he was talking about getting his 500 hours, et cetera, et cetera. And I was talking. I said, it's one of my goals to do that this year, to actually get that, not because I want the CPRS after my name, but just simply because I'd like to get back into some of these practices that I learned about that I've never put into place.
Yeah.
The recovery coach training that we do here at McShin is phenomenal. Like we've got this big thick book, and I took it 3 years ago. When I had 3 months clean, or 3 months of recovery. And so, it's a lot of practical lived experience since then, but putting that and contextualizing that with the plan, seems like a good idea for me. So thank you. Now
You're welcome.
Well, and so, the conversation. So when I was talking to Kyle earlier, we're talking about what it meant and what you needed to be to become a certified peer recovery specialist. So I believe, and please correct me if I'm wrong, I believe 1 year of continuous recovery.
That depending on what you read.
Okay.
And there are some conflicts in what you read, that you should have a year before certification. How much you should have before training is open to interpretation. Now, somebody may email me and correct me, and maybe even post a comment. But
please.
That's a little bit flexible. When I have selected people for training, I want to see a significant commitment to recovery.
Yeah.
Because there are people who have a year in recovery and what they do is not terribly noteworthy. Whereas there are people who are really working their ass off who may not have a year.
Yeah.
And those are the people you want to see, that you want to train.
Yeah, no, exactly. And I think that, that pink cloud can cloud a lot of our thinking, early on. It certainly did with me. I guess the question is, I know that we talk a lot about here at McShin about fatigue, compassion fatigue.
Yeah.
And I think, for some of us, that can lead to more mental health challenges. It can also lead to relapses or
it can.
reoccurrence of use, know. And so as a peer recovery specialist, what happens in that situation? I'm not planning it out for me.
Please don't. Please don't.
But it's sort of
please call me first.
One of these thoughts that it's coming. How do we? I guess a better way to frame this is, how do we protect our peer recovery specialists from the inevitable, stressors?
Yeah.
Because as a person with lived experience, I share my experience with the next person.
Right.
And the danger for me becomes that I'm constantly reliving micropses of my addiction and putting that back out. Now, see, I have to be very careful to put that back into place and recontextualize it into my recovery. But if I don't do that, and I've seen this. This is why I'm bringing it up. Is what can we do for each other to ensure that we are keeping each other safe?
Talk to each other.
I
mean, that's the simplest.
Call me first. I love it. Thanks, Cambria.
Right. Yeah. Talk to me. Call me. I'll call you. I had a situation last week where somebody I've known for quite a number of years and worked with as a client in several contexts came in with just some of the worst self-injury I've ever seen. And it really knocked me for a loop. I'm one of those people that stays calm in a crisis. And 23 and a half hours later, it knocked me upside the head. Well, I have two people who have significant experience on both the committing it and helping people with it, and I call them and talk to them, and that brought me down because I got home that night and I was okay, and then the next afternoon I was really, really, really just, almost tortured by it. It was really, really getting knocked upside the head by it. And still talking about it, really it's an emotional event. We work with people who in some cases have just profound emotional, mental health and substance difficulties. And so I do my recovery stuff. I made a point to come to Richmond last night, spend the night with a friend who's I collect psych nurses as friends. I have four psych nurses who were friends, and so I stayed with one of them last night. And just talking through our common history, working together for a number of years. But also gallows humor helps. I've gotten in trouble for that before, but it really does help. There is humor in lifeboats, and I've actually gotten in trouble for it. But that's one way to do it. I have friends who are connected with emergency departments and rescue squads. And if you can't occasionally laugh, you'll cry all the time, and that, are we laughing at somebody's expense? Generally not. Are we laughing to stay sane? Yes.
Yeah. How long were you a house manager?
Well, I was trying to figure that out. I started in 2002, and then around 2011, it was decided that the housing I was managing wasn't going to be managed housing anymore. So 2002 to 2011.
2002 to 2011. Yeah. What does that entail? Sorry, you wanted to drink.
Yeah, let me take a sip.
Well, so this is a good time. So what I'll do is I'll look and say, Cambria says again, and I'll get to Robert's question in a minute, but Cambria says, I watch every live I catch. I've never been an addict, but I am fully committed to helping Kyle succeed. I watch to learn ways I can help him. I love it.
And call me first.
Yeah. That's good. So what is being a house manager at
this was at Region 10.
At Region 10, yeah.
It's being a mentor, setting an example, having a commitment to recovery, although not everybody was in recovery.
So you could have house managers who weren't in recovery from a mental health or
we had people who weren't.
Interesting.
But who were stable people who could. We managed meds at the time. We held people's meds locked up, and things like that. and and just keep the house stable. Now, these were small houses. These were houses with 2 people each in them, and some of us managed a number of them. They were in a cluster in a neighborhood. But it was basically to keep the place safe. That was it, more than anything else. The programming was done during the day at a center for the most part, and we were there to help people stay safe at night.
Okay, and I imagine each person would have an individual recovery plan.
Yeah, each person had an individual treatment plan. Because this was a Medicaid-funded organization, so it was a formal individual service plan and so on. But recovery support was a part of that.
So, what was the average, stay of an individual?
There were people
14.
Oh, there were people who were there for 6 months, and there were people who were there for 12 years. There were people for whom that really was permanent housing.
Okay.
And and again, I mean, talking about this being a deadly disease, we lost somebody. My, back of the envelope calculation was somewhere between every 14 and 16 months, we lost somebody. Yeah. People with serious mental illness die approximately 20 years earlier than their average cohort. We're still trying to figure out why. Pretty sure that smoking has a big part to do with it. Meds probably have a big part to do with it. And lack of self-care.
Yeah.
You put all those 3 things together, and again, serious mental illness is a deadly condition too.
Yeah.
So that kind of gets a little bit apart from what you were asking about being a house manager, but again, safety was the single biggest thing.
Yeah. I know that you came with, I think, a 10-page.
Oh, I've been skipping around. We've got everything. We've covered almost everything. I'm really looking at our recovery advocacy project. I can't remember what we're calling this. What's the?
It's our platform.
It's our platform. Yeah. But there's a name for the particular image thing that we've got on our website.
Gosh.
I know. We'll think about it.
Well, yeah, we're failing at advocacy right now. But I do want to get to Robert's question.
The content is what matters.
Robert Legg, who's a longtime listener.
Yeah.
Robert, have you been on the show? I think you might have been. But anyway, are advanced directives being used for mental health patients? Could advanced directives also be used for substance use disorder?
Yeah, advanced directives can be used for anything.
Okay.
And it is a part of the peer certification training to be able to talk about them. Now, sadly, in Virginia, now the only people who can assist people or be trained to assist people doing advanced directives are basically prescribers. Doctors, nurse practitioners, physician's assistants. There was a set of training a number of years ago, and my understanding is that a number of people who had some self-interest in doing them felt that trained nurses, trained peers weren't, adequately competent to do them. But of course, you can do it on your own. I am totally forgetting the name of the site, but if you Google Virginia Advanced Directive, you'll get the site that has the forms. You can download them. You can fill them out. They're simple to fill out. And then there's one where you can include mental health stuff. And technically, if you diagnosis wise, substance use conditions are mental health conditions. So just kind of by incorporation, substance conditions can be included in an advanced directive just because they're mental health conditions. And you tell in it what you want, who you want to do it, what you don't want, and so on. If you have a wellness recovery action plan, you can attach it to it. And then you can, there's a state website you can upload them to. You can carry a card. I've got one in my wallet that says, if I get dragged into an emergency department, it's got the link to my specific advanced directive, so they can pull it up in the ED. Also, the 2 places I go, in Charlottesville, UVA, and Martha Jeff, I fax them copies into my medical record years ago when I've had different treatments at both places. And so you can make sure they're everywhere and accessible. And they're critical to have because lots of us in mental health recovery and substance recovery have varyingly helpful relationships with our family members.
Yeah.
And advance directives are critical for that, because if you don't have one and something happens to you and you can't speak for yourself, it literally is a majority vote of your relatives that show up at your bedside. So if your preferred sibling to speak for you is in Utah and they can't get here in time, and you have two relatives in the area that you don't get along with, they get to decide what happens to you.
Ooh. Ooh, I mean,
that they're critical. And it's something, I mean, it's something like 3% of the people in recovery, 5% of the people in recovery have them. And you can go to the website and fill one out in 20 minutes.
You know what? That's really helpful information, because I'm glad you're bringing this. I'm glad, Robert, for bringing that up.
Thanks, Robert, for the question.
Actually, you've met Robert.
Yeah, on Zoom.
On Zoom. Because I don't have one. In fact, I remember the part of that training, and then I remember thinking, whatever.
Yeah.
But this, you know, I think I have a Fastmart value card in my wallet. I get discounts on monsters.
And not mental health treatment.
Not mental health treatment. Robert, thank you. Robert's putting the link into the comments right now.
Great.
VirginiaAdvancedDirectives.org.
Yeah. And it's done through the UVA Institute for ILPPP, Institute for Law, Psychiatry, and Public Policy.
Okay,
is who it's done through.
That sounds like a really interesting group of people.
It's a great group of people.
Yeah.
If I had a different lifetime trajectory, I would love to have worked with them at some point.
I love it. You brought up the Recovery Advocacy Project.
Yeah.
So, yeah, right. You can see the time right up there too. We're at 32. We'll go to.
We got loads of time.
Yeah, we got loads. And I usually right around 48, I start to bring the plane down.
Okay.
You know, we start bringing the seats back up to the full upright position.
Lock your tray tables and the last 10,000 feet are the risky part.
You never know what's going to happen at the end of this show. We'll say goodbye, and then 20 minutes later, we're still going. Well, you should have seen us when we had my mom on a few weeks ago.
Oh, I didn't see it.
Yeah, on June 14th, we did 5 shows that week.
Wow, you must have been beat.
Well, Justin, really, because Justin is also responsible for the Sunday. I know, right? Look at that, muscles. He's responsible for our Sunday programming here too. We do what's it called? Breaking the bondage of addiction. Breaking the bondage of addiction. I'm sorry, Walt. I'm sorry, Jesse. Breaking the bondage of addiction. It's a beautiful ministry that we do down here, a non-denominational spiritual service.
Great.
So, yeah. So, bringing up the Recovery Advocacy Project here, how did you get involved with that? And then we can talk about these certain points. I think it'd be really cool too.
I first came across it by reading Ryan's book.
Oh.
I think I have the audio book of it.
Ryan Hampton.
Ryan Hampton. Yeah. Who wrote a book about the history of and current, or at the time, 3 years ago, I guess, current state of the opiate crisis and so on. And, he merged two things beautifully, which resonated with my own history living in San Francisco through the early and middle days of HIV/AIDS, was saying that basically what we need is the equivalent of ACT UP for substance use treatment and substance use recovery. That until everybody who has a personal connection with substance use issues comes out, advocates, talks to all their family members, and talks to their providers. Doctors get 8 hours of substance use training in medical school.
Oof. Wow. And we're talking 22 million people in the country with a substance use disorder.
Yeah.
Wow.
And the average family practitioner has gotten 8 hours of training.
8 hours of training.
Yeah.
So for those who may not know, and there's probably a lot, tell us what is ACT UP? What is that?
Okay.
What is that?
ACT UP was the first, started in New York, in your face AIDS advocacy group that literally lay down in the streets. And people chained themselves to the FDA fence, confronted Tony Fauci, who we've known since the days of HIV/AIDS, And ACT UP, and Larry Kramer, the playwright, really became good friends with him, was in his face just constantly during the early days of
Kramer
AIDS.
became friends with Fauci?
Yeah.
Oh,
yeah,
wow.
Yeah. And Larry died a couple years ago, and there was a memoir where he talks about, I think it was an article where he talked about their friendship and the fact that he really sort of flipped Tony Fauci into becoming much more of an advocate for treatment than he was. He was very much a, sort of staid scientist, and became much more of an advocate for treatment than he was. And it's interesting because he, what's happened with COVID and his being there. He had that history of responding to community needs, and I think, and we really saw that. I mean, there was a big parallel between HIV/AIDS and COVID in terms of initial denial, don't want to deal with it, don't want to talk about it. And with COVID, that led to some confusion where, and we're getting way off track, but
No, it's fine.
this is a something important to me. Science changes, and people were and still are upset. Well, the CDC said this last week, and today they're saying this week. Science changes, and we realized that in the early days of HIV/AIDS too, because nobody knew anything when it started. But anyway, back to Ryan's book. That's where I first found out about what he was doing, and thought, hey, this is something that I'm interested in. I participated in Mobilize Recovery virtually last year. I'm hoping to go to Vegas this year, and meet everybody face to face. I'm sort of in a weird position. Working for the Commonwealth, I feel a little bit held back in terms of how much public stuff I can do. I can certainly talk about anything personally. So I've been helping out a lot, writing stuff and hosting listening sessions and stuff like that.
Yeah.
Which is how I've been doing it. But anyway, what Ryan said was, until everybody talks about recovery, talks about overdoses all the time to everybody they know, when you go to your doctor for your next appointment, talk about recovery. If you have a family member who is either in recovery, needs recovery, talk about it. Talk to your pharmacist. I think I remember him saying, talk to everybody. And that's what happened. That's one of the things that ACT UP did, was literally involve everybody in your circle of life and advocate that way. That an awful lot of the advocacy is personal. What we're doing is more public oriented. But at the same time, a lot of what we're doing is personal too, because we're trying to get all the people in our circle of support to sign the petitions and so on.
Yeah. I like the parallel with ACT UP. Because I was, when I got here to McShin, one of the first things with John, Shinholzer here, helped me to see recovery as the civil rights movement that it is. And the parallel with the the LGBTQ plus movement, and the
BIPOC movement,
and the BIPOC movement. I'm part of the LGBTQ plus, and I remember, I'm a little bit younger than you, but not much younger, but I'm a little bit younger than you. And I remember, the 80s. I remember hearing this, and I hear it, and I've talked about this on the show recently a little bit, because I'm sort of re-examining those things, and recognizing that I still have a lot coming from that. A lot of my responses to the world comes from, those experiences as a child, listening to, God hates F's and that sort of, and recognizing that, it was a huge deal when Ronald Reagan first acknowledged that AIDS was a thing.
Yeah, and it took him somewhere between 3 and 5 years. I don't remember the exact period of time, but yeah.
I don't remember the news lines that said gay cancer or this or that, but I do. Yeah. And so we talked about this a little bit yesterday, and remembering the obituaries on a regular basis.
Yeah. So, I mean, I remember when the number of deaths in San Francisco was in the 20s. because the weekly sort of bar rag gay newspaper kept count as best they could. And I can't remember when, and I mentioned this to you yesterday, I can't remember when in the early to mid 90s there was actually a week with no obituaries. And how moving that was for all of us, because that went from 81 to the mid 90s with people dying by the dozens, hundreds, and thousands. I mean, just about every gay person I know from the 80s is gone. Pretty much everybody. And there's a wonderful book, and it's going to take me 5 minutes to remember the name of the author, on sort of that internalized loss, internalized grief that we all feel. And also, the internalized, Walter Detz is the author. And he's a photographer and a psychologist in Berkeley.
What's the name of the book?
Oh, I'm drawing a total blank. You're gonna have to look it up. I've got it on this, but
I think I've got it on Audible. That's why I was
I have the Audible. I have the Audible one too. And that sort of, and actually that goes back to my early drinking and using. Was I had this sort of internalized homophobia of knowing that the world hated me. And I buried a lot of it through my early drinking and drugging. It was a way to sort of put that all on a shelf and not deal with it. And that's something that, I mean, it's way down there now, but every now and then it comes up, when am I going to come out? When am I going to say this? When am I going to say that? Do I need to say this? Is it relevant? And I moved to San Francisco in 1979, and the famous line was, San Francisco, where the love that dare not speak its name won't shut up. But
I've never heard that, but that's the Oscar Wilde quote, right?
Yeah, it's the Oscar, it's the love that dare not speak its name, and then somebody added that won't shut up.
That's awesome.
But then you sort of come and go, and sometimes even if you don't go fully in the closet, you don't talk at work about it or whatever. And that still happens. Far less now because, most of the time I don't give a rat's ass what anybody thinks, but that's the advantage of getting old.
There is that. And, I haven't really been practicing, but anyway.
But that internalized stuff, I mean, there's guilt, there's grief, there's shame. And that for a lot of us was a foundation of why we use substances. And also in turn, the view of both substance use and mental health conditions is that we've got a genetic predisposition and then crap happens in our lives. And that's a part of the crap that happens in our lives.
Well, and so to that end, the response of the LGBT community at the time, was to speak out, act up, but also an internal health brigade effort, to provide condoms, to talk about safer sex. And so what I love, what the parallel I see here is, of course, the Narcan, because
interesting.
The overdoses are I guess essentially the people dying of AIDS, I guess is the parallel. And the Narcan, and it's individuals, like us with lived experience who go out and do that work as non-judgmentally, and then we get into harm reduction.
Exactly.
And so you wanted to bring that up, and I'm so glad you want to bring that up. So what did you want to talk about on that?
Well, I didn't even really know until 2 or 3 weeks ago in one of the Zoom things that Carol Cruz did as part of their recovery advocacy project, that there really is a whole social movement of harm reduction. It's not just us going out and saying we need Narcan, we need needle exchange. Vancouver has been doing safe injection sites. Someday that may come here, but
I think didn't Rhode Island just pass something? But I don't think the governor has signed it yet. But
okay,
I'm
But that's for this country. That's really sort of bleeding edge stuff. And it's just happening in a few places around the world. But there's little bits of things too. We talk about harm reduction. as, sort of the bits and pieces of it, but it's also a social movement because, among other things, an awful lot of the overdoses much more significantly affect marginalized communities.
Yeah.
And so there is that social justice component to it. And I didn't know that till 3 weeks ago, 2 or 3 weeks ago.
Yeah.
So, we're all still learning. I was going to tell you a story about it, and this is something that I told in one of the Zoom calls that Carol was doing, where a couple of years ago, when I was out working at the crisis stabilization unit, we had somebody who came in who was routinely driving from Charlottesville to Richmond to score heroin, do it there, and then drive back to Charlottesville. And one time, I believe they even had their kid in the car with them.
Mm-hmm.
And some pretty horrible stuff happened the night the kid was in the car. Well, the person said, if I can smoke pot every day, I will stop shooting heroin. And we said, okay. We said, if smoking pot every day, which is not going to kill you today, keeps you from shooting heroin, which can kill you today, for today, that's fine. And that's harm reduction. And 10 years ago, that would have been considered malpractice. It's still pretty cutting edge. I'm sure there are going to be people listening to this who are going to go, wait a minute, somebody really said that? But that's harm reduction. Harm reduction is keeping people from killing themselves today, so that maybe tomorrow we can find recovery. Or maybe even later today we can find recovery because we're not dead.
Well, and I think, and so I've actually learned a little bit about something recently too, is that, the harm reduction itself is also recovery.
Oh, absolutely. Yeah. Absolutely. We have this, and for some of us, it is biologically woven in. I cannot do anything. Okay. That's how my brain is hardwired. I can't do a little bit of this, so I don't do more of that. Because if I do a little bit of this, I'm going to do even more of that.
Right.
For me, water can be a gateway drug. I mean, that's a joke, but I can't do anything. But there are people that can. Yeah. And, in the history of 12-step programs is you got to stop everything.
Yeah.
Well, and here's where stuff gets sort of misconstrued over decades and decades. The big book was written when there were 100 sober people who nobody thought would ever get sober. And so we're basing a lot of our recovery on stuff that goes back to 1935 that deals with the worst cases. But there's a lot of other people who aren't the worst cases. And so, if you can do a little of this, then do a little of it. But if you can't, then you're going to have to start looking at total abstinence.
Right.
But it's a spectrum. It's not a yes or a no thing for an awful lot of people.
And I think, to your point, we just, as you know, legalized adult use cannabis, recreational adult use cannabis here in Virginia on July 1st, and it's certainly been bouncing around in my own head. Maybe I could do this successfully. Mm-hmm. And fortunately, I have a program that teaches me I don't have to worry about that today. If I can worry about it tomorrow. And for me, it doesn't look like I'm going to do that today. Yeah. I'll worry about tomorrow. Mm-hmm. But I know that that's a struggle. Like the fact that it's legal now is a struggle for me in my own thinking, and I'm very much in favor of it for many, many, many reasons.
Well, we're harm reduction
for harm reduction, and black market, the criminal aspect, and of course putting anybody behind jail, behind bars because of drugs is abhorrent to me. But I know that my own personal recovery is important. It's important for me to have these conversations with people I trust, people who've got long-term recovery, people like my sponsor or my mm-hmm. people in my network, because, ultimately my recovery goals are to find some serenity, some peace of mind. Right. That's my ultimate goal. And it's something that, like, when you saw me having a conversation at the end of a conversation with my coachee earlier, mm-hmm. he was on the phone, right? And on the board, we had talked about goals, and he gave me a goal, and he would put it at the very top. Mm-hmm. We said, "Well, how do we get to that goal?" And so we talked about all these steps, and I said, "Well, what does that goal? What does your life look like there?" Mm-hmm. And what I wasn't hearing from him was peace of mind and serenity. And I'm not going to shove his face in the water. It's just, it doesn't, I need to get to that, I need to get to that. So I used my own lived experience. I'm saying, and I was telling this very long and involved as a story, the way I can tell a story long and drawn out. We both can. Yeah. But I was telling the story, and he's like, what's the point? I said, well, I just told you all this stuff, and none of this actually relates to what's going on. I completely took you, and I said, what's my goal of peace of mind and serenity is being thwarted by me focusing on this giant piece of nothing over here, which I was actually really focusing on, but I was being more elaborate in my. So anyway, that's it's important for me to recognize that I got to have people in my life who can give me perspective.
Yeah, who call me on my
shit. You can say
what.
Shit here.
Okay. Okay. Well, we just did.
Debbie Rosenbaum, who's a board member, she says, Nathan, thanks for having Tom on today. Great conversation. I'm now living in the Region 10 area, and I can't read from here.
It's nice to put a face to the organization.
On another note, the quilt made and displayed by families who are honoring their loved ones during the AIDS epidemic were incredibly powerful. Did you ever see the quilt?
Oh yeah. I mean, again, it started while I was living in San Francisco, and the storefront that it was stored in, we made panels for a number of my very close people. And I saw it the last time I think I saw it both times in DC. And took my best friends in Charlottesville to the last time it was there. And I still start to cry whenever I think about it. It's so interesting that in New York, ACT UP started in New York, and everybody was, it was all in your face and in the streets, and we were making quilts and, and caring for each other, in a very loving way. And it's just sort of so interesting how the two coasts, and at some point did sort of meet in the middle, where, one headed west and one headed east. But there really was quite a divergence between the two coasts.
Well, and we can see the parallel in the recovery movement by, arguing about harm reduction, and by arguing about decriminalization, discussions about, what is recovery, abstinence-based people who say, well, if you're not abstinence-based, you're not in recovery. And so, these are the divisions, right? And I think when we find, and I think that's what we've done a lot with this recovery advocacy project, what we've done here is we examined how many, 10 maybe listening sessions that we had.
Yeah, 6, 8, 10, somewhere
6,
in
8,
there.
10, something where we had, where we invited anyone, and the recovery advocacy project, you can be anyone, to be a part of the project, but to simply, to turn up at one of these grassroots listening sessions and advance an issue. And so many of these things that came on here, some of these things, a lot of these things I know about, but so many of these things and the way we worded them, really surprised me, because they weren't necessarily things in my brain. And which is great, because
that were in mine.
It's not all about me.
and so it's not. And so well, if it's not about you, it's about me. Right. But some of these things, just one or two people mentioned, and we talked about it some more, and it made it into our platform. So, one or two people can make a difference. One or two people can make a difference if you start, at the grassroots and move up. One or two people can make a difference in terms of putting an idea out there. I mean, there are things that we never thought about. You could put 3 or 4 of us in a room, we might have thought of half of these things. And other people brought up stuff that was critical to them, including more cultural competency in the peer training. The current training manual has 2 paragraphs on cultural competency.
Wow,
that's it.
And
so, and I know Chantel, our peer in Virginia Recovery Advocacy Project, she brought that up.
And which is and you do the training.
I looked it up in the book, but she brought up the issue.
Didn't even really, I'm so kind of used to not being in front, that particular issue, that aspect of my life not being really thought about. So it didn't even dawn on me that, maybe we should have a little bit more information. So that was really helpful. And that also led to, how we work. Well, I think the recovery residence part led to this. together, these issues are important, but making sure that we have non-discriminatory affirming housing for all people,
all people,
and
yeah.
LGBTQIA plus and BIPOC people too. So a lot of this stuff has been really important. What I didn't do was give any information to Justin to put up there. So what I'll do is I'll make sure we have this up on Thursday, because I was slacking today. But we'll get this information up for Thursday so that we can have this and have people endorse it. Because the important thing now is for us to look at this, for us to look at the language and look and say, you know what, I believe this too. I'm a person in recovery. I'm a family member of a person in recovery. I'm an ally of people in recovery. And this is what I believe. And I believe that, we believe in equitable access for all. We believe in peer recovery support services. We believe in eliminating barriers to recovery. 3 simple concepts.
Well, I first heard John on it was probably a YouTube video 3 years ago, 4 years ago, where, or it might have been on a Facebook link. But anyway, he was speaking somewhere and he was talking about same-day access. And back then, you'd walk into a CSB and you would say, I want treatment for my substance use issues. And they would say, fine, come back in 3 weeks. Well, what percentage of people came back in 3 weeks? Now, there have been some advances where they are all supposed to be providing same-day service. Now, that's a same-day intake. If you get there by 2 p.m, and if they have everybody to see you, otherwise you have to come back in the morning. So there's still work to be done there, just in terms of a same-day intake. And some of them are working on shortening the time between the time you walk in the door and the time you see somebody who can actually help you. Although getting an intake is helpful. That was certainly my experience when I first walked in the door there. Just going, I walked in the door, really helped. But still, there was a period of time between I walked in the door and I saw somebody who could really help me. And how many people get lost in their statistics are anywhere between a quarter, a third, maybe more, who just never show up for that appointment, how many ever days or weeks later. And I was telling my friend this last night, talking about reducing criminal issues of substance use. Some number of years ago, the chief of police in Gloucester, Massachusetts said, I'm tired of putting people in jail. It's costing me all this money to run my county jail. And he started saying, okay, fine. You walk in the door, or you are arrested for a small possession charge, and you say, I want treatment. I will get you in treatment that day. And they would literally park you with a peer until there was a bed found for you anywhere in the state. Now, small state, geographically, we will park you with a peer until we find a bed for you, and we will get you to that bed and we will pay for it out of the money that they were spending on incarceration. And wow. I don't know, that was probably the better part of 5 years ago. I don't know what's going on with it since, but I'd love to go back and find out, how successful it's been. But that's same-day access.
Yeah, there's a similar program. It sounds like a similar program in Maine, the Operation Hope / Project. Is it Project Hope? Project Hope, I think, is what it's called. / Operation Hope, I guess. 2 sides of the same coin. That essentially you can present yourself to an emergency department, a hospital, a police department, fire department, and say I need help, and they will detox you, and they'll send you to. I think you have a couple different places you can go, but one of the places is here in Richmond, and we've had a lot of people from Maine go through that. But
interesting, because finding a detox bed in Virginia, it's the bad joke is it's easier to get into Harvard than it is to find a detox bed in Virginia.
That is one of the most frustrating things about being in this business.
The private hospitals have gotten totally out of the business of it. The public hospitals do everything they can to not do it. And there is a very small number of private substance treatment facilities that do it. And so getting somebody who needs medical detox, getting them into it while they are willing to go is just it's a nightmare.
So what? And I realize we're coming up on the hour, but
wow.
But what
We're at the hour. Wow,
We're
that
at
was
the
fast.
hour, yeah. So
that was fast.
So there's a gap, that's the gap, right?
Yeah.
And I know Step Virginia Step Virginia would, I don't know where that starts. Step VA, attempts to fix some of these things,
Right.
and I know that Senator Deeds and his commission, they're doing a lot of work to try to improve services and whatnot. And I have some issues with him and his substance use disorder, but I know that there's an approach coming. There's an approach coming from wanting to help, the desire to help. And I think that the gap that is filled by the non-governmental organizations that are providing these recovery support services, that are actually doing this. I talk about this a lot here. They're actually doing the same day access. Excuse me, same day access, not just same day assessment. And I think that's the important gap that you've identified. Having somebody there, it's making sure that we have people at the emergency departments, for an overdose, for a substance use related emergency. Having a peer there who can not just say, here's a you saw what we got last session. Okay. Oh, here's a flyer with some resources.
Right. Here's a card with some resources.
We had, there was a bill. It was a beautiful bill. Couple sessions ago, peer recovery specialists and every tomorrow, but just getting to that, we went from having peer recovery specialists in emergency departments and beds and time and thought, to here's a flyer. We couldn't even give them Narcan. That's another story.
Or now one of the things too is getting emergency departments to give people a supply of Suboxone to get them to an outpatient appointment, 3 days, 7 days, whatever it takes. They're little tiny, individual docs in EDs that are starting to do that. But this should be everywhere.
It should be.
It should be everywhere. Especially now the Biden administration got rid of the waiver requirement for starting to prescribe Suboxone. You don't have to go to the training anymore for 30 patients. You can just write a script for it. And that was one thing the Biden administration did pretty quietly, maybe a month ago. You used to have to go to, I think it was an 8-hour training and get a DEA waiver to have 30 patients on Suboxone. Now you just write the scripts.
Okay.
So that was a step they made in MAT that actually was kind of under the radar. It really didn't get announced much. But at the same time, I'll certainly acknowledge there was progress. Some of my mentors and friends who have been in the treatment world for 30 plus years, when you walked into Region 10, 25, 30 years ago with a co-occurring mental health and substance use issue, they would say, come back in 30 days when you're sober for us to treat your mental health condition.
Oh, wow.
Okay. So there's been progress.
Okay. Progress, not perfection.
Yeah.
Right?
And to get back to Step VA is a great idea, but guess what it doesn't have? Funding.
Yeah.
It's a great idea, but an awful lot of those ideas there's no money for. And so
yeah.
I mean the words are great, but in order to get stuff done, it's going to take money.
Tom, I love it. You're speaking to the choir. Man, I've really appreciated having you on the show today. And I think we could probably easily go another 2 or 3 hours.
Did we have any questions we didn't get to?
I think we got to everything. We had somebody talking about medical marijuana. What did she say? You want to read that? Because my eyes are...
Okay, yeah. I'm a medical marijuana user for mental health. Being a cannabis activist, I'm very much in favor of the legalization of this. But when my dispensary looks like an Apple store, it's time to free up a lot of incarcerated humans. A lot. Well, that's certainly true. And, one of my concerns about full legalization and so on is that then it becomes a profit-making business for people. And yes, there's going to be tax money from it, but at the same time, some of the dispensaries are going to look like Apple stores.
Yeah. We'll talk. Yeah. Well, that's, I wish we had another hour here. Proud of you both. Have a kick-ass day from Cambria again. Thanks, Cambria.
Thanks, Cambria.
To see you. Good to see you, Debbie and Robert. I hope you got to watch all the way through. It was good to see you. But any final thoughts? Anything that we didn't get through here that you wanted to bring up, Tom?
I think we covered on a lot of stuff. I can't think of anything that we didn't talk about, except to let people know that they can go to the Virginia Recovery Advocacy Project Facebook page, and there's petitions to sign. There's 3 so far. There's 1 on that 10% set aside, and then it go to community mental health or community organizations. Sorry, did it go to community organizations? And the 2 LGBTQIA plus ones that we wrote about culturally sensitive training and culturally appropriate supportive housing.
Yeah.
And all 3 of those are at the Recovery Advocacy Project, Virginia Recovery Advocacy Project Facebook page.
Yeah, I'm trying. Is it facebook.com/
I don't know what it is.
If you do a search for Virginia, we'll get better on this. I do want to say, Tom, thank you so much again for being on the show. Justin,
thank
you for being here and being a great producer. But before we go, McShin is celebrating 17 years this month. And the reason I bring this up is because, we are a non-governmental organization providing that authentic peer recovery support and have been for 17 years. We are not Medicaid reimbursed. We are not fully funded. We're marginally, nominally funded by government organizations. And in fact, some of our funding recently just changed over to VAR, which is a good thing. I think, giving VAR an opportunity to spread it a little bit. But, we are able to keep the doors open. And I think it really panned out, especially in the last year and change months, 15 months, while COVID has been through and other organizations, governmental organizations, have had to close their doors or put on these incredibly restrictive access points, whereas McShin kept the doors open every single day. And I'd like to say I was here every day, but I went and drove around the country. But we were able to keep that doors open, and so the only reason we've been able to do that on a daily basis, every single day for 17 years, is because of contributors. We get our bed fees. We get some grants here and there, funding and whatnot, but a big portion of how we survive, how we're able to provide this kind of content, how we're able to provide beds for people right as they need them, that immediate access, that same day immediate access, is because of funders like the fabulous people listening to the show and watching right now. So my point is, check out McShin's page, check out the McShin Facebook page, watch the little videos. We're going to have a video every single day for the next, I don't know how many days, but we've got a whole bunch of videos going through. I know that I've got a little video in there somewhere. Cool. Talking about, I don't know what I'm talking about. I did it yesterday with honesty, and but 17 years. Cambria, I will make sure that we have a link to the donation page somewhere at some point. I appreciate you there. I failed a little bit today to be more prepared. So, but on that note, recognizing we've been around for 17 years, and this is an incredible accomplishment, and I'm so proud to be a part of this. I'm so grateful to have Tom, 30 years of recovery, still in here, going strong, talking about the praises of and showing that recovery is not only possible, but you can put together a plan and do it. Justin, grateful to have you here. Everybody listening, yada yada. I love it.
Thanks, Nathan.
Anything
I
else?
Really appreciate it.
Yeah, man, I appreciate you too. Thanks, everybody. We'll see you tomorrow for Women Wednesdays, and Thursday we got a treat. We go across the pond, across the Atlantic, and we talk to Anthony from I'm not going to name it's Voltiface. I'm going to forget trying to pronounce it, but what it means is a whole change of thinking and a change of thinking about the way that we do recovery advocacy. So check out tomorrow for the women. Check out Thursday for some across the pond ideas. Take care, guys.
Here at McShin, we believe in the McShin way, which is authentic recovery support service providers, people with lived experience, bringing that experience to those who need that lived experience in recovery.
Here at McShin, we believe in many things to support our mission. We believe in women empowerment.
What I love most about what we believe here at McShin is we believe in the authenticity of the peer-to-peer approach.
Here at the McShin Foundation, we believe in giving people opportunity.
Here at McShin, we believe in the inherent worth and dignity of every person.
At the McShin Foundation, we believe in helping people reach their full potential.
Here at the McShin Foundation, we believe in multiple pathways to recovery.
Here at McShin, we believe in placing principles before personalities to help spread hope.
Here at McShin, we believe that recovery is possible and that any person seeking recovery can become a more acceptable, responsible, and productive member of society.
Here at the McShin Foundation, we believe in self-discovery.
Here at McShin, we believe in saving lives and offering second chances.
Here at McShin, we believe you can do this.
Here at the McShin Foundation, we believe that we can only keep what we have by giving away, which is why we continue to help others like us seek and find recovery.
Any place, we'll get there.